Yes, sir. Yes, sir.
Thomas, just one word. What is the order?
Yeah, so Dr. Bhupesh Karthik will go first with examination. Seema will go second with imaging. Dr. Subra will go third with the rotator cuff, and you are fourth with the shoulder instabilities.
Oh, fine.
So the participants actually WhatsApp the questions to me if there are any, and then I will ask the speakers because they're watching it on YouTube.
Done. Okay.
Good evening, everyone. We welcome you all to OrthoTV online. This webinar is called the Bone School and is one of the highest quality postgraduate education in the country. And to introduce today's program and the speakers, I will hand over to our convener and moderator, Dr. Thomas Kishen.
Thank you, Neeraj. Good evening, everybody. So Bone School is a orthopedic trainees teaching program that has been going on since 2012. So we run monthly sessions, and each session or each month is dedicated to a separate subspecialty of orthopedics. So we have knee 1 month, we do shoulder 1 month, we do pediatric orthopedics, we do tumors, we do spine, hip on separate months. So this month we're going to focus on shoulder, and we have excellent faculty from across India, and I take pleasure in introducing them. So we have Dr. KN Subramanian. Dr. Subramanian has been with Bone School right from 2012 when we started. He's been here every year. Dr. Subramanian was my colleague in Bangalore. He's moved to Madurai, and he's a dedicated shoulder and knee specialist. The second faculty member I'd like to introduce is Dr. Bhupesh Karthik. Dr. Bhupesh also is a very keen teacher, has been involved with Bone School in the past. He works out of SBS Hospital in Hosur and from Chennai. Dr. Seema Janardhan is our radiologist. So Dr. Seema is a colleague of mine at Manipal Hospital, Bangalore. She's a specialized musculoskeletal radiologist and very good at her work, as a result of which we trouble her all the time asking for opinions on scans. And Dr. Sushal Shanthakumar is my colleague in Manipal. Dr. Sushal is a dedicated shoulder specialist at Manipal Hospitals, Bangalore. I take this opportunity to thank all the faculty for taking time off to take part in Bone School. I also thank OrthoTV, Dr. Neeraj and Dr. Ashok, without whose help we would not have been able to broadcast this. And as you are aware, the reach of OrthoTV is enormous across all continents. And we are very grateful to Dr. Ashok and Dr. Neeraj for helping us broadcast our sessions. Thank you very much. And with that, we start Bone School. The first speaker is Dr. Bhupesh Karthik, who will be talking about examination of the shoulder. That will be followed by Dr. Seema, who will be talking about imaging on the shoulder. Then we have Dr. Subramanian talking about rotator cuff pathologies. And the last will be Dr. Sushal Shanthakumar, who will be talking about shoulder instabilities. Now, since you're watching this on YouTube and Facebook Live, if you have any questions, please feel free to WhatsApp it to me. My number is 9980-400-858. And once the questions come to me, I will put them across. I will ask the faculty and they will answer it live for you. Thank you very much. Thank you for joining us. And I hand over the screen to Dr. Bhupesh Karthik.
Thank you, Thomas Kishen, sir. It's always a very nice thing to come back to Bone School, meet yourself and Dr. Sushal. I've enjoyed every bit of my Bone School experience. And with that, we will start this presentation. So usually the shoulder case is kept as a short case for postgraduates. And you have to keep practicing this flow chart in your mind again and again, because you will only have 5 minutes to go through your short case and come with a diagnosis. So okay, before starting to examine any shoulder case, you have to make sure that the patient is in standing or sitting position on a stool. The neck and both upper limbs have to be exposed. In male patients, you can expose till the waist. The limb should be kept freely hanging by the side of the chest in anatomical position. And because God has given another limb, you always have to compare your findings with the opposite shoulder. Like in any other joint examination, it starts with the inspection, goes on to palpation, looking for deformities, movements, measurements, and then special tests. Always start your examination of the shoulder with the neck, because most of the time, neck pathology can also give rise to shoulder pain, details of which will be covered in the spine session of your bone school. So, like anything that you like a car or a bike, you have to inspect from all sides. From the front, the things that you see are your SC joint, which is here, your clavicle, which is between this, and your AC joint, which is here. You will also see the supraclavicular fossa and the infraclavicular fossa, your anterior axillary fold, your deltoid contour, and your pectoralis major muscle, and your trapezius. You will compare these with the opposite side, look for wasting or any prominence. In the axillary fold, you will also compare it to the opposite side and look for fullness in the anterior axillary fold. For example, this is a classical case of clavicle non-union. You can see the clavicle going up like that, and you know this deformity has got something to do with the clavicle. You will then start looking everything from the side. You will look at the deltoid bulge and its insertion into the proximal humerus. From the back, you will start looking at the scapular borders and compare with the other side. You will look for the trapezius on both sides, and you will look into the supraspinatus fossa, which is above the spine of the scapula here, and the infraspinatus fossa, which is below the spine of the scapula here. Compare it with the opposite side and look for wasting. Again, you will look for the deltoid contour and see if there is any difference from the normal side. The posterior axillary fold should also be looked into and look for fullness. Now, all palpations should be divided into three: palpation of the bones, palpation of the joints, and palpation of the soft tissues. As we saw in the inspection, the same structures are now palpated. The palpation usually starts from the sternoclavicular joint. You will go along the clavicle, then reach for the AC joint, and then you will palpate the acromion in the side and continue posteriorly along the same line to palpate the spine of the scapula. Then the proximal humerus and the coracoid process, which is just under the lateral side of the clavicle, should be examined and look for tenderness. The anterior and posterior glenohumeral joint can be examined. The AC joint should be palpated. Again, the sternoclavicular joint should be palpated. These are fairly superficial joints and are easy to palpate. The soft tissue below this lateral aspect of the acromion, where the subdeltoid bursa is present, should be palpated and tenderness should be looked for. And you will also do a quick axillary examination when you are palpating. Okay. So the three important bony points in palpation are the tip of the coracoid process, tip of the acromion in the anterior aspect, and the greater tuberosity. Many old-timer examiners would want you to look into movements by the Codman's method. I will come into that. If I am visible here. Okay. So this movement is forward flexion or elevation. The same thing backward is extension. Bringing this arm to the side is abduction. Bringing the arm inward is adduction. And this is external rotation with arm in 90 degrees. And this is internal rotation with arm in 90 degrees. The same thing can be checked by the side also. Okay. With the arm by the side of the chest, you will look for external and internal rotation. So this is the Codman's method. Okay, you will use your right hand to examine the left shoulder and vice versa. The thumb, you will palpate the clavicle, acromion, and the spine of the scapula. The thumb is placed below the spine of the scapula in that manner. The index will go to the anterior aspect of the acromion, and the 3 fingers will stay on the clavicle. This will stabilize the superior roof of the shoulder joint, and your hand will grasp the patient's flexed elbow and movements are elicited. By this way, you will prevent trick movements of the shoulder, and true movements of the shoulder can be examined. You will do measurement of your arm length. You will do measurement of your forearm length, and you will look for muscle bulk in the arm and forearm segment and look for wasting. Lateral slide test is to look for scapulothoracic dyskinesia. The inferior pole of the angle of the scapula to the spine of that particular level is measured and compared to the opposite side. It is usually done in 3 places: when the arm is by the side, when the arm is kept over the hip, and when the arm is at 90 degrees and in maximum internal rotation. So you will do these 3 measurements, and you will look for variation between the left and right side. And if there is gross variation, it means there is scapulothoracic dyskinesia. Now, all this you should have finished in a matter of 1 minute and 30 seconds. Now, in the remaining 3 minutes and 30 seconds, you will quickly look into the case and start to understand if it is an instability-based case, that is a labral pathology-based case, or if it is a rotator cuff-based case. So most of the instability-based case will have a history of dislocation when you are eliciting history. Okay. So acute dislocation, you will of course do the Dugas test, where you will not be able to, where the patient will not be able to touch the opposite shoulder. Your Hamilton ruler test, where your ruler will be along the lateral aspect of the arm, because the deltoid contour is lost since the humeral head is dislocated anteriorly, and the regiment patch sign to look for any paresthesia in the side of the arm where your military badge is there to rule out axillary nerve injury. Now, all these 3 tests are very theoretical for an exam base and very practical for in real life, because in exam acute dislocations usually will not be there. So don't worry about them. But you will look for instability cases in your exam, patients with anterior instability, posterior instability, or multidirectional instability, and the following tests should be done. After you do the test for anterior and posterior instability, test for SLAP should be done. The SLAP is lesions in the labrum between 10 o'clock and 2 o'clock, that is superior half of the superior most part of your shoulder glenoid. And this acts a little differently because the biceps tendon is attached there. So lesions between 10 o'clock and 2 o'clock in the superior labrum is called SLAP lesion, which is coined by Snyder. SLAP stands for superior labral anterior to posterior lesions. Okay. And then you will look for biceps lesions, which can be there along the groove of the biceps. Sometimes patient can present with Popeye sign because of rupture of the long head of biceps. The biceps will come down and will have a Popeye sign here, the bulged biceps. You should know how to look for deltoid atrophy and test it by resisted abduction in 90 degrees. And then you will do your AC joint tests. We'll go into those. Now, if your case is not a instability case, then it can be an impingement or a rotator cuff lesion case. So if you know that there is no dislocation in the history, then if the pain is the only problem, then you will quickly start doing all these tests. Now, before doing all these tests, you should know if the patient has got a stiff shoulder, which means your diagnosis will be more of adhesive capsulitis. So the first thing that you do is to look for external rotation with the arm by the side of the chest. If the external rotation of the involved upper limb is less than the other side, then you're looking at an adhesive capsulitis kind of a picture. But if the external rotation is equal, then if the patient has got pain, then you might be looking into something of an impingement or a rotator cuff lesion. So your mind should now be ready to understand if the patient is an adhesive capsulitis case or an impingement and rotator cuff case or an instability case, because you will not have time to do all the Humpty number of tests that is given in your textbook. So you will have to narrow down your testing pattern. So we will first look into instability based case. First, rule out multiligamentous instability. You will look for your Brighton score and see if there are other signs of ligamentous laxity. The most important test for anterior instability is your apprehension and relocation test. This is a provocative test. It is best done with the patient lying down. Okay. Sorry. Yeah. You will abduct and external rotate. You can see what the patient is doing. He becomes apprehensive because he feels that the shoulder is going to pop out. Now, when you give an anterior directed force on the proximal humerus and do the same movement, abduction and external rotation, patient appears to be safe. So when the arm is abducted and externally rotated, the humeral head tries to escape anteriorly, and because the anterior labrum is torn, patient will have a sense that he is going to dislocate his shoulder, and with apprehension he will ask you to stop. Now, when you give an anterior directed force on the proximal humerus, you are preventing the anterior escape of the humeral head, thereby relocating it, and the apprehension will be missing. So this is the anterior apprehension test and the relocation test. In thin-built patients, you can stabilize the scapula like that and hold the humeral head anteriorly and posteriorly and do a shift and load test. It is very difficult to do in muscular individuals because the deltoid will not let you hold the humeral head. But when you can hold it, you can push and see how much the humeral head translates anteriorly and posteriorly, and compare it with the opposite side to identify anterior and posterior instability. The sulcus test is done with patient in by the arm in the side at 0 degrees and 45 degrees. An inferiorly directed force is given, and the humeral head comes down, forming a dimple there. And this is suggestive of rotator interval laxity. Okay. Now, posterior instability basically aims at trying to recreate apprehension with the arm in flexion, adduction, and internal rotation, and then posteriorly pushing it. Now, this is the important position: flexion, adduction, and internal rotate. In jerks test, you first bring it to 90 degrees, internal rotate, axially load, and then bring it horizontally, which is adduct. In apprehension test, you make the patient lie down. This is a better test. And then put your hand behind the humeral head, flex, adduct, and internal rotate, and then give a posterior directed push on the elbow. And then you can feel the humeral head translating posteriorly. And of course, patient will have apprehension. Now, the O'Brien's test, adduction, and then in maximum internal rotation, you now grab the patient's wrist, and the patient has to horizontally further adduct and flex the shoulder against your resistance. That is suggestive of a positive slap lesion. The crank test, you will bring the hand to 90 degrees of abduction, load the glenoid by putting a axial load on the elbow, and you will crank the shoulder by alternately internal and external rotating, thereby creating pain in the slap lesion area, and patient will complain of pain. Now, the biceps lesion test, you have two, the Speed's test and the Ergoson's test. Without flexing the elbow, resisted forward flexion of the shoulder will give rise to pain along the bicipital groove. When the patient should complain of pain here, and if that is positive, your biceps lesion is present, and this is the Speed's test. Since biceps is also a fantastic supinator, you flex the elbow to 90 degrees and you do supination, resisted supination. And when resisted supination again gives pain here, it is a positive lesion, positive test for biceps lesion, and this is called the Ergoson's test. The AC joint is palpated first, and when the arm is cross adducted, the patient should complain of pain on the AC joint. This is called the finger sign. If the patient says, I have pain here, which is called the palm sign in the back of the shoulder, it indicates posterior capsular tightness. But if the patient complains of pain on the AC joint, pointing with a finger, then the scarf test or the cross adduction test is positive for AC joint pathology. Now, impingement test, the most simple test and very reliable test is the painful arc. Patient will have pain in mid-range abduction between 60 degrees to 120 degrees. After 120 degrees, the shoulder becomes pain-free, and after 60 degrees downward, usually there is no pain. In and around 90 degrees, there will be maximal pain, and this is the painful arc. Now, the impingement test, you have Humpty number of tests, the Hawkins-Kennedy, the impingement test, impingement sign, everything involves trying to squeeze the supraspinatus and the infraspinatus between the greater tuberosity and the acromion. So you can do it in the impingement test with 90 degrees of abduction, or you can do it in forward flexion and internal rotation, where again the GT will squeeze the supraspinatus under the acromion, which is the Hawkins-Kennedy test, or you can do the empty can test with the arm in 30 degrees of forward flexion, abduction, and internal rotation, and you will resist the patient's movement of the arm upward and outward, and this will give rise to pain along the anterior aspect of acromion, and this is called the empty can test, like you're emptying a can of water. Subscapularis is a fantastic internal rotator. Now you will explain to the patient that you will be doing this, and you will ask him to push out, and then you will push the hand back and look for the power and compare it with the opposite side. Because it is very difficult for the patient to understand this, you will first show him what you are going to do and then do this. This is called the Gerber's test. The other test is the belly press test. You will ask the patient to press his belly. If the internal rotator is strong, then the hand will stay in forward and it will not drop backward because the subscapularis is intact. So that is the other test. Testing for infraspinatus is resisted external rotation test with the arm by the side, and you will compare it with the opposite side to look for the difference in power. When there is a complete rotator cuff tear, you will have the drop arm sign. Okay, at around 90 degrees, patient will not be able to hold the hand and maintain, and this is a painful test sometimes, so you will have to have your hand underneath the patient's elbow, and you will not allow it to fall down with a painful thud. Okay. Now, many PGs have been asking me to add this in my shoulder examination slides. Scapular winging can be kept as a short case if it is there in your ward or that day. Otherwise, it will usually be a theoretical question. You basically have to understand that patient has got scapular winging. It could be either medial winging or lateral winging. Medial winging is usually like this. It is more pronounced medially and it goes superior. And this is because of the serratus anterior, which is paralyzed, and it is supplied by the long thoracic nerve of the bell, The lateral winging is usually because of the trapezius. You can see the difference here. The trapezius is missing, and the superior angle of the scapula will be more lateral, and that is lateral winging. That is because of injury to the spinal accessory nerve. The rhomboid palsy, because of injury to the dorsal scapular nerve, also is there, but the most common ones are the medial and lateral winging. You will ask the patient to do a push-up motion against the wall to enhance the medial winging. External rotation resistance in an abducted arm will enhance the lateral winging. Okay, so these are two things. Identifying them and testing these muscles is more than enough in a short case, and the examiner will be very happy that you have done that. Thank you.
Thank you very much, Dr. Bhupesh, for that excellent lecture. There was a question. Number one was, how do you differentiate between pain from the shoulder versus radicular neck pain?
Thomas sir, I lost you for some time. I think I was on mute. Can you come again with the question?
Sure. So there was a question on how do you differentiate between shoulder pain and cervical radiculopathy?
Yeah. I think the history itself is very important in identifying this. About the cervical radiculopathy, I think Thomas sir will give you a short idea right now. But shoulder pain per se is usually due to impingement or adhesive capsulitis. These pains are more pronounced at night.
So, yeah, no, thing is, yeah, like Dr. Bhupesh Karthik was saying, shoulder, so history very important. Number two is we do something called the Davidson's test. So if abduction of the shoulder and you put the arm on top of the head, if that relieves the pain, so if you put the hand up like this and that relieves the pain, that's supposed to be quite classical of cervical radiculopathy. Whereas clearly in shoulder pathologies, that hyperabduction is going to increase the pain. But having said that, it's still very, tricky. I used to send patients to Subra when I used to work with him, and now Sushal. Sometimes there's so much of overlap. So sometimes what we give is a diagnostic local anesthetic subacromial injection. And if that relieves the pain, then we can say, oh, it's probably, there is some shoulder pathology also. So yeah, but very important to differentiate between the two shoulder pathologies because they also can sometimes radiate down the arm a bit up to the elbow. So, and can be quite tricky sometimes. So yeah, that is only one question. Thank you, Dr. Bhupesh. Can we go to Dr. Seema for her talk on imaging of the shoulder?
Hi, good evening, everyone. I'm Dr. Seema Janardhan. I'm one of the consultant radiologists at Manipal Hospital, Old Airport Road, Bangalore. At the outset, I'd like to thank Dr. Thomas Kishen for giving me this opportunity to talk today. And also, I would like to apologize. I'm actually recovering from a chest infection. So if I start coughing right in the middle, kindly excuse. So we'll be talking about MRI of the shoulder. So MRI of the shoulder is the most commonly asked MR examination, mainly because shoulder pain is one of the commonly encountered problems. And understanding the MR shoulder is very important because the anatomy can be quite complex and variable. And with proper understanding, we can actually provide accurate interpretation and also minimize the reporting errors and increase the diagnostic yield of the shoulder MR. So the objective of this session is to briefly take you through the technique, some anatomy, and also commonly encountered pathology in shoulder MRs. So conventional MR, we usually perform it in a supine position with arm in slight external rotation. And we usually use a dedicated shoulder coil because it improves the resolution of the imaging. And the images are acquired in three planes, mainly the coronal plane, and it is usually in an oblique plane rather than true coronal because we want the images to be parallel to the supraspinatus tendon and the scapula of the spine. The axial images are obtained from just above the AC joint to include the inferior margin of the glenohumeral joint. And we also obtain sagittal oblique images which are perpendicular to the supraspinatus tendon. Most of the centers now have 3T MR, which actually gives a very high resolution as compared to 1.5. But most of the diagnostic centers still do 1.5, which is pretty good for majority of rotator cuff pathologies, whereas small abnormalities such as labral tears are better picked up on 3T conventional MR. 3T provides increased signal to noise ratio, also known as SNR, which improves the diagnostic accuracy of the imaging. And for this as well, we use dedicated phased array shoulder coil. MR arthrogram is a special procedure where approximately 12 to 15 ml of dilute gadolinium is injected into the shoulder joint under X-ray or ultrasound guidance. It's a reasonably well tolerated and a very safe procedure, which actually increases the diagnostic yield as compared to the 3T conventional MR. And the indications for shoulder MR arthrogram are shoulder instability to evaluate labrocapsular complex. Sometimes undetected rotator cuff tears can also be picked up, and it's quite useful for post-surgical cases. Imaging usually is done within 30 minutes of injection into the joint. Moving on to the anatomy of the glenohumeral joint, it's a ball and socket type of synovial joint. It is very mobile, and instability of the shoulder joint accounts for more than 45% of all shoulder dislocations. And the joint is actually formed by the two bones, which are the glenoid bone and the humerus. It is reinforced and kept in place by multiple soft tissues around the shoulder joint. We'll be talking about that in the next slide. These are called the shoulder stabilizers. And the joint stability actually now depends on multiple factors in two positions. One is in the static position and one is in the dynamic position. In the static position, the negative pressure of the joint itself increases the stability of the joint, as well as certain structures like the ligaments and the capsules, as well as the glenoid labrum. The joint fluid is also quite sticky, and the adhesiveness of this joint fluid also adds to the joint stability. But once the shoulder starts moving, there are multiple other structures which come into action, which help improve the stability. The majority of these are the rotator cuff muscles. These we'll be talking about in detail later on. In addition to the rotator cuff muscles, we also have deltoid and biceps muscles adding to the stability, and the nature of the cup, that is the glenoid concavity itself, adds to the stability of the joint. The joint capsule is a very thin structure which actually attaches medially to the glenoid neck, outside the glenoid labrum, and laterally to the anatomical neck of the humerus. At multiple places, the capsule actually thickens to form band-like collagenous structures, which are called as the glenohumeral ligaments, which are three: the superior, the middle, and the inferior glenohumeral ligaments. Of these, the superior glenohumeral ligament is the most consistently identified ligament, and it usually originates from the supraglenoid tubercle just anterior to the origin of the biceps tendon. Coming to the most important structure of the shoulder joint is the glenoid labrum. It's a fibrocartilaginous extension which deepens and increases the surface area of the glenohumeral articulation. It actually varies in thickness. However, standard about 4 millimeter has been described in the literature. It goes all around the glenoid articular surface. So how does labrum look on MRI? This is an axial section. This is an axial section where we can see this is the glenoid bone and this is the labrum. It looks dark on all sequences and looks triangular. This is the posterior labrum, this is the anterior labrum. They should look homogeneous with no abnormal signal within the labrum, either anteriorly or the posteriorly. The posterior labrum is usually larger and more consistent when it comes to morphology as compared to the anterior labrum. So coming to the labral pathologies, the most important one we need to be aware of is the Bankart and a few variants of the Bankart. So Bankart's lesion actually refers to injuries to the anteroinferior labrum and usually caused as a consequence of anteroinferior dislocation, and usually is located between 3 o'clock to 6 o'clock position. Sometimes Bankart lesions can actually extend to the superior labrum as well, but they are quite uncommon. They're typically seen in the anterior aspect. So this is a classical Bankart. So this is the anterior labrum here. We have a tear through the labrum and the periosteal layer here. This is a classical Bankart. When a part of the bone is gone, it's called the osseous Bankart. When it actually happens in the posterior aspect involving the postero-inferior labrum, it's called reverse Bankart. And these are certain other variations which we'll talk about if time permits. So what is a classical Bankart? It is a detachment of the anteroinferior labrum from the underlying glenoid and usually happens secondary to anterior dislocation. And it always is associated with a matching humeral lesion, what we call as a Hill-Sachs lesion, which is a fracture at the posterolateral superior aspect of the humeral head. And we talked about bony Bankart. Sometimes they can also be associated with partial or complete rotator cuff tears. So this is an example here of a classical Bankart. This is an axial section. As we can appreciate, this is an MR arthrogram. The joint is grossly distended with fluid. There is a depression in the posterolateral aspect of the humeral head here. This is the classical Hill-Sachs lesion. There's some edema going on in the underlying bone here. And this is the glenoid bone. And as we can appreciate, that normal triangular morphology of the anterior labrum is now lost and it looks quite fragmented and there is some surrounding debris here. As we go down, we can appreciate that the anteroinferior labrum is very blunted, demonstrates some abnormal signal changes. So this is a classical soft tissue Bankart. We do not see any bony abnormality here, so there is no bony Bankart. And this is the sagittal view of the same thing. So this is the Hill-Sachs, which is a large defect here in the humeral head with associated bone marrow edema. So how does it look on the axials? So this is the glenoid bone here, and as if you can appreciate that the anterior labrum is now completely separated with joint fluid now extending deep to the labrum, and we can see that there is also discontinuity of the periosteal layer here. So this is classical Bankart, and this is the pictorial depiction of Bankarts here. Perthes is another variant of Bankart. So what happens in Perthes is normally the labrum is separated from the glenoid bone and the periosteal layer is actually separated and discontinuous. However, the labrum is still attached to the periosteal sleeve here. So this is a classical Perthes. When there is medialization of the labrum with stripping of the periosteal layer, it is called an elapsa lesion. So moving on to the next important labral pathology is the superior labral anteroposterior tears, also known as slap lesions. These are nothing but detachment of the superior aspect of the labrum from the glenoid rim that can extend anteriorly or posteriorly and sometimes also inferiorly to the adjacent structures. It's most commonly seen in throwing athletes such as baseball and tennis players, and also in swimmers. So depending on the type of slap tears, they have been categorized into 8 categories and sometimes more as well. But routinely, we try to follow nomenclatures between type 1 to type 4. So this is a classical example of a type 1 slap lesion where we can see that there is irregularity and fragmentation of the superior labrum, but it remains attached to the biceps tendon. And this is what we see on MR. We see that the superior labrum is now looking slightly irregular and fragmented. However, there is no fluid extending into the labrum or into the biceps tendon here. So this is type 1 slap tear. Type 2 slap tear happens when there is detachment of the superior labrum from the bone and the tear is seen extending into the biceps tendon attachment but not completely, and there is fluid signal between the superior labrum and the superior pole of the glenoid bone. And this is how it looks on MR arthrogram. We see that the joint fluid is now extending beyond the labrum and also extending into the biceps tendon. Type 3 slap tear is when the labrum is completely detached and moved out and it is separated from the biceps tendon as well. So it's called a bucket handle tear. So we appreciate that the fluid is now going through and through, extending across the labrum and also separating the labral fragment from the biceps tendon. Type 4 slap tear is a split tear of the biceps tendon along with tear of the superior labrum. So what happens here is we appreciate that the fluid signal is now going through and extending into the biceps tendon and now traveling along the long axis of the biceps tendon. On MRI, that gives a double Oreo cookie sign. So we see that there is labral fragment, then we have the fluid here extending, then a little bit of labral fragment again and fluid. So it looks like a stack of Oreo cookies put on top of each other, also known as double Oreo cookie sign. So these are the major labral tears. There are certain labral variants one needs to be aware of, which are the sublabral foramen, Buffert's complex, and some labral types, as well as synovial recesses. Because of time constraint, we're not going into the detail. If anybody is interested, Radiology Assistant is a very good website which gives more details about the labral variants. Moving on to the next important pathology is the rotator cuff pathology. The rotator cuff is consistent of 4 muscles which blend along with the fibrous capsule and provide dynamic stability to the glenohumeral joint. Of these, the supraspinatus is by far the most important muscle, followed by infraspinatus and teres minor muscles. These 3 actually attach onto the greater tuberosity, along with another major anterior stabilizer, which is the subscapularis tendon, which inserts onto the lesser tuberosity. Along with the rotator cuff muscles, we have an important structure, which is the biceps muscle and tendon, which also forms a part of the shoulder complex and provides anterior stability. The biceps tendon has 2 heads, the short head, which arises from the coracoid process, and we have the long head, which attaches from the supraglenoid tubercle, runs along the bicipital groove and joins to form the muscle belly in the proximal arm. So how does rotator cuff insertion look on sagittal MR? This is how it looks. This is the morphological depiction. So we have the glenoid surface here, the glenoid labrum here, and right at the 12 o'clock position, we have the long head of biceps brachii tendon attaching onto the supraglenoid tubercle. And just around that, we have the rotator cuff tendons coming in. So between 12 o'clock to almost 2 o'clock to 11 o'clock positions, we have the supraspinatus tendon, and posterior to that, we have the infraspinatus tendon, and inferiorly, we have the teres minor tendon attaching. Anteriorly, we have the subscapularis tendon between the 2 o'clock to 4 o'clock positions. So this is the rotator cuff attachment. Normal MR signal, all tendons appear low signal on all MR sequences. Except for a certain phenomenon called the magic angle phenomenon, where we can appreciate high signal on short TE sequences without increase of the signal intensity on long TE sequences. So what it actually means is when certain fibers, normal fibers of the supraspinatus tendons are orientated at about 55 degrees to the main magnetic field, there is a pseudo appreciation of high signal even in a normal tendon. So this actually happens at about 1 centimeter from the insertion of the supraspinatus tendon onto the greater tuberosity, and this angle effect is called as the magic angle effect. So if you see abnormal signal, particularly in that position, then we always tend to do comparison with our conventional spin echo T2 weighted sequences to make sure that this is not an artifact. Coming to the classification of rotator cuff tears, they can be classified into either full thickness tears, partial thickness tears, or massive tears. So a full thickness tear is one which extends from the articular surface to the bursal surface along the supero-inferior aspect of the tendon thickness. When the tendon tear extends from the anterior to the posterior aspect of the tendon surface, it is classified either as complete tears or incomplete tears. A partial thickness tears can be either articular or bursal or intratendinous, depending on the location of the tear. And the terminology massive tear is used when there is full thickness tears involving multiple tendons of the rotator cuff, usually involving the supraspinatus and infraspinatus. Partial thickness tears are more common than full thickness tears, and these are more common also on the articular side as compared to the bursal side, and intratendinous tears are relatively rare. So here we have example of a normal looking supraspinatus tendon. This is the supraspinatus muscle, and this is the tendon attaching onto the greater tubercle here. This is the foot plate of the supraspinatus, and as you can appreciate, just about 1 centimeter proximal, you can see some high signal here. This is what we call the magic angle effect. This is a completely normal tendon because there are no other signs to suggest abnormality. On the right, we have an abnormal tendon, so we can appreciate the muscle here and the black tendon coming in, and as it comes here, we can see that there is some high signal here, and we can appreciate that there is actually a fluid cleft. The tendon is also relatively thickened as compared to a normal tendon here. So this is an abnormal tendon, probably a tendinopathic change, along with probably an early intratendinous signal change here. Now, when we appreciate tears, we always compare the signal with the joint fluid. So a tear is called a tear only if the signal intensity matches the signal of the joint fluid. If it is less than that, it's unlikely to be tear and probably tendinosis. So what happens in full thickness tears? See, there are direct signs as well as indirect signs. The most common direct sign of a full thickness tear is complete discontinuity of the tendon and also associated high signal changes on T2 weighted images. And we tend to see fluid gap here in the tendon gap, and we also see retraction of the myotendinous junction. So these are the direct signs of a full thickness tear. Usually full thickness tears are associated with distension of the subacromial subdeltoid bursa, which is this here. And if left for too long, the muscle can undergo fatty atrophy. So chronic tears usually present with muscle atrophy. Partial thickness tears can demonstrate high signal on both T1 and T2 weighted images. So we can see that there is a fluid cleft going through the foot plate of the tendon here, but this is a partial thickness tear because we do still see some intact bursal surface fibers. And as I mentioned, this fluid signal matches the fluid signal of the joint here. And tear fills up with gadolinium on MR arthrogram. As compared to degeneration, the intrasubstance signal change in degeneration is not as bright as the joint fluid. This is the important take-home message I'd like to mention. So I have examples of a couple of partial thickness tears. So here, this is a partial thickness tear involving majority of the articular surface fibers with a few bursal surface fibers being intact. So this is a high-grade partial thickness tear involving the articular surface, or we can also call it a near full thickness tear. Image on the right demonstrates discontinuity of the bursal surface fibers here with intact articular surface fibers here. So this is a partial thickness bursal surface tear, and also appreciate distension of the subacromial subdeltoid bursa. So probably this was a case of subacromial impingement. This is an example of a massive rotator cuff tear. One can appreciate that the acromioclavicular joint is significantly degenerated, and there is a complete tear with tendon retraction of the supraspinatus tendon. The same case on the sagittal sequence, we can appreciate that there is also tear involving the supraspinatus, infraspinatus, as well as the subscapularis tendons here. So we do not appreciate any of these tendons coming onto the bony insertion. So what do we actually expect out of an MR report when we see tears? It's very important to describe the depth and thickness of the tears, the shape of the tear, the amount of tendon retraction, extension of the tear into the adjacent structures, also to describe the degree of muscle atrophy and fatty degeneration, and also a comment on the coracoacromial arch and impingement to see if that is the cause for the rotator cuff tear. So when we actually see a tear, how do we classify? Depending on the size of the tear, they are classified into small, medium, or large. Large tears are usually 3 to 5 centimeters. Medium is 1 to 3 centimeter, and anything around 1 centimeter or less is classified as a small tear. Depending on the depth of the partial thickness tear, they are graded into 3 grades, grade 1, 2, and 3. Normally, the rotator cuff is about 10 to 12 millimeter thick, and we call them as grade 3 tears if there is more than 50% involvement of the cuff thickness. The next important point is to talk about the tendon retraction. What it actually means is retraction of the tendon significantly to the medial aspect suggests that it is an irreparable tendon. So in this case, we have a complete tear with retraction of the tendon, which is now located almost at the glenoid surface. If it is associated with muscle atrophy, this tendon repair is not going to do well. So we need to comment on the position of the retracted tendon stump, either in relation to the glenoid articular surface or acromioclavicular joint. So this is another example of an axial sequence where there is retraction of the subscapularis tendon, which is now located almost at the level of the glenoid surface. Tear extension into the surrounding structure also indicates poor prognosis. If it anteriorly extends, it can involve the coracohumeral ligament as well as the superior surface of the subscapularis muscles here. Sorry, this is subscapularis here. And if it extends posteriorly, it can go to involve the anterior most fibers of the infraspinatus tendon, and very rarely can extend into the teres minor tendon as well. The next important thing in an MR report is to talk about the muscle atrophy and fatty degeneration, because it actually impairs the functioning of the supraspinatus muscle. And if there is significant atrophy, it is usually associated with tear recurrence even after repair. So how do we evaluate? There are a couple of signs or ratios that we calculate. The first one is the occupation ratio. So this is the suprascapular fossa, and this is a normal supraspinatus muscle with no fatty atrophy. And you can see that this actually fills up the majority of the suprascapular fossa. So this orange shade is the ratio of the suprascapular fossa, and we can see that the supraspinatus is larger than the area of the supraspinatus fossa, as against this here, which is an abnormal muscle here. So we can see this is the tendon here, and the muscle is now atrophied, and the occupation ratio is much less as compared to a normal muscle. The other sign is called the tangent sign, where we draw a line over the superior surfaces of the coracoid and the spine of the scapula. The supraspinatus, a normal supraspinatus muscle, should cross this line and above. If it is below this, then it is called fatty atrophy. So depending on the degree of degeneration, they are graded from 0 to 4 according to Gautelier. So grade 4 usually means very poor prognosis and suggests that there is more fat in the muscle than the muscle fibers. So this is an example of grade 4 muscle. Clearly, the subscapularis is also undergoing similar changes, as well as the infraspinatus. Last couple of slides to talk about other associated tendon tears. Biceps tendon tear is a commonly associated pathology with supraspinatus tears. We appreciate that there is no tendon here in the bicipital groove. Normal biceps tendon looks like a black ovoid structure here. In this case, we do not see this, so it is likely a tear. And we also see dislocated biceps tendons, especially there is full thickness tear of subscapularis, because subscapularis keeps the tendon within the bicipital groove and reinforces it through the transverse humeral ligament. So when there is a complete tear of the subscapularis muscle, the biceps tendon tends to move out of the bicipital groove and is seen medially. This is called medialization of the biceps tendon. Isolated infraspinatus tears are very rare and usually occur after acute trauma and can be associated with posterosuperior impingement. And similar to the supraspinatus tears, we can appreciate that there is retraction of the tendon here with associated fatty atrophy here. And if there are partial thickness tears, infraspinatus tendon tears are usually undersurface tears and they are associated with labral pathology. Finally, we'll talk a couple of slides about subscapularis tendon tears. These are usually associated with anterior shoulder dislocations and anterosuperior impingement. And as I showed earlier, they are associated with long head of biceps tendon dislocation. So here is an example of a complete subscapularis tear. And we can see that it is completely detached from the lesser tuberosity. And it is showing some increased signal changes and can be either thick or thin depending on the degree of tendinopathy, and we can appreciate that there is some medialization of the long head of biceps. So how do I report my MR? This is the structured pattern that I follow. Now always talk about the alignment of the glenohumeral joint, presence of the effusion, then talk about the cartilage structures, presence of any bony signal changes or fractures, comment on the labrum, labral tears or any labral variants. Then we talk about acromioclavicular and coracoclavicular joints to suggest that if there are any degenerative changes which could be leading to rotator cuff abnormalities, type of acromion, rotator cuff status including biceps tendon, presence of any abnormal bursae, also talk about the capsule and glenohumeral ligaments as well as periarticular soft tissues. This is how my MR shoulder report is usually structured. And these are the reference websites if anybody is interested in seeing any more and reading any more further. Thank you.
Thank you, Dr. Seema, for that fantastic lecture. I hope our audience enjoyed it as much as we all did. Very comprehensive lecture. Thank you very much. Despite being not too well, thank you very much for coming. Much appreciated. There aren't any questions for you, Dr. Seema, so we'll probably let you go and then we'll move on to the next lecture. Thank you very much. So the next speaker is Dr. Subramanian, who will be talking about rotator cuff pathologies.
Good afternoon, Thomas. Good afternoon, whole Bone School team, which has been running.
Good afternoon. Yeah.
Can you hear me well?
Yes, you're clearly audible.
Thank you. So thanks for your continuous perseverance and hard work about Bone School, and so many postgraduates are getting benefited with this. And last month, I think we had the knee meniscus session, and this month is shoulder session. So thanks for inviting me again. My talk is going to be on rotator cuff pathology, very especially about the rotator cuff tear. So first to show you, I'm going to talk about some basic anatomy and what is the function of the rotator cuff in relation to the shoulder joint, and what is the etiology of the shoulder pain and rotator cuff pathology, and then we'll slowly go into the investigation and management of various type of tear. So if you look into this model, you have this anterior, this is posterior. Anteriorly, we have this subscapularis here. Posteriorly, we have supraspinatus, infraspinatus, and teres minor. And this is seen in the sagittal cut. As you can see here, end-on view of the glenoid, with supraspinatus just below the acromion. Infraspinatus is also below the acromion, teres minor over here, and subscap is just below the coracoid process. But if you look into the attachment of the supraspinatus and infraspinatus, it is not a single point attachment. It is attached in a very wide area, as you can see, it's painted in the orange and green form. Supraspinatus has got a footprint area of about 6 by 12 mm, and infraspinatus has got a footprint area of about 10 by 33 mm. So remember, when you are thinking about a 1 centimeter tear, the tear has gone only just beyond its footprint area, not beyond that. So, and partial tears never go beyond this particular area at all. So partial tears and full thickness tears are two different entities, which will let you know in next few slides. So we would have heard about many pathologies like rotator cuff tendinosis, intrasubstance tear, partial tear, and full thickness tear. So if you look into this is the same pathology at various severity. So somebody can have a just simple pain. Somebody can have pain with loss of function. Somebody can have pain with loss of function and also degeneration also. So they all can be in one pathology. All are due to the cuff tendinosis. If the severity goes to intrasubstance tear, and then it can become a partial tear, and the partial tear can become full thickness tear. When you see a full thickness tear, a tear can be a small tear, or a medium tear, or a large tear, or a massive tear. Small tear means it's just gone just to the beyond the footprint area, which is around 1 centimeter area. The medium tear means about 1 to 3 centimeter, which is gone right up to the middle of the humeral head. If it is crossing the middle of the humeral head going up to the glenoid, it's about 3 to 5 centimeters. It's called large tear. Once it has gone beyond the glenoid, which is proximal to the glenoid, means it is more than 5 centimeters. It is called a massive tear. So this is a classification done by Cofield classification. It's called as, and this may be useful for exam and exam ask you about, and also it may be useful in theory also. So what is the function of the rotator cuff? So rotator cuff is, we all know it as, it's a supraspinatus is an abductor, infraspinatus is an external rotator, subscapularis is an internal rotator, and teres minor is an external rotator at about 90-degree level. So for example, if somebody does 90-degree abduction and the external rotation at this level is done by teres minor, and at neutral position, the external rotation is done by the infraspinatus, and abduction is done by supraspinatus, and internal rotation is done by subscapularis. These are the 4 major actions of all the 4 rotator cuff muscles. Hello, Thomas? Yeah.
Sorry, your slides are not seen.
Really? Oh, wait. Okay. How is it now?
Sorry. Yeah, you have to share screen.
Sir, you have to reshare the whole thing.
Okay, fine. Can you see it now? Are you able to see it?
Yes.
Yeah, we can see your screen now, Subram. We can see your screen.
Okay. So, did you see the second slide?
Yes.
Okay. So now going to the full thickness rotator cuff tear, it is small tear, medium tear, large tear, and massive tear. And small tear is within the footprint area, medium tear is up to the middle of the humeral head, large tear is just before the glenoid, and beyond glenoid is massive tear. So function of rotator cuff is first is supraspinatus does abduction, and infraspinatus does external rotation, subscapularis does internal rotation, and teres minor does external rotation at the level of 90-degree of abduction. So this is not the only function of the rotator cuff. Rotator cuff has got another major function called stabilizing effect, which is called dynamic stabilizer. As we all know that for glenohumeral stability, inferior glenohumeral ligament is very important. but that is a static stabilizer, and it works in the static phase and also in the abduction also. But dynamic stabilizer means we keep constantly moving around the shoulder at any position, and at all the position, the humerus is centered in the glenoid. This fantastic function is done by the rotator cuff working in coherence. The supraspinatus, infraspinatus, teres minor, subscap, all the four muscles work together to give this dynamic stabilizing effect. And it keeps the humeral head and the center of the glenoid all the time, and that is called concavity compression effect. So this is the most important function of the rotator cuff rather than abduction and external rotation. All these functions are individual function of the muscle. And this can be called as a power generator for the shoulder. In other words, if a shoulder joint without rotator cuff can be called as a functionless shoulder or almost like a useless shoulder. That is what it happens in a rotator cuff-less shoulder joint. So another thing is subscapular is the most powerful muscle of all the four rotator cuff, and that is called as almost like a power generator or accelerator for the shoulder joint. So what happens if the rotator cuff is not functioning? So for example, as we know that all the four muscles work together to keep that concavity compression effect. We imagine the supraspinatus is torn now. So other two muscles, like for example, subscapularis and infraspinatus is working, but supraspinatus is not doing that compression effect. So automatically what is happening is the humeral head will start migrating up. So very first finding that you see in a patient having rotator cuff tear is proximal migration of the humeral head, and hence the acromion to humerus distance becomes narrowing. So normally the acromion-humeral distance is about 1 to 1.5 centimeter. If you find that distance is narrowed, which is less than 0.7 mm, for 0.7 centimeter, for example, then rotator cuff tear is invariably present in those patients. So X-ray itself can give a clue for you when you are thinking about rotator cuff pathology. Next is, what is the etiology of the rotator cuff problem? So there are several etiologies that have been thought of, hence it can be called as multifactorial. But the common thing is the repetitive overhead stress. For example, like in a sports player or somebody who is in a job whose job involves like lifting his hand up, like for example, a painter or a masonry worker or an electrician or a teacher whose job involves keeping the shoulder in the above the level of the shoulder joint, like the overhead activity, then they have more chance of getting stress over the rotator cuff, and they can get rotator cuff pain and symptoms related to that. And the next thing is anatomic, and then intrinsic and trauma. We'll go one by one. First thing is the sports thing, where somebody doing overhead activity. So if you imagine a play which has got overhead activity like cricket, tennis, badminton, volleyball, javelin throw, all these have got overhead activity throwing. And all these involve heavy movement of rotator cuff muscles. Without the good function of rotator cuff, one cannot do the overhead throwing activity efficiently. So if you see this phase of classical throwing, somebody does like a cricket bowler or a volleyball player, they have like 5 phases that can be split up while they are doing a throwing movement. Wind up is a session where the weight of the back foot and the whole torso is transferred to the shoulder joint. And early cocking is where they do the external rotation. Late cocking is at a place where they are doing extreme external rotation, almost 165-degree external rotation. And then the acceleration is given by when they are doing the throwing movement, and that is generated by the subscap muscle, and then they go to the follow-through activity. But throughout this phase, the whole function of rotator cuff is going, one group of muscle doing concentric contraction, other group of muscle doing eccentric contraction. Concentric means where the length of the muscle shortens when they are contracting, and eccentric means the length of the muscle either lengthens or stays same with increasing tension. That is eccentric contraction. So if one group of rotator cuff muscle is concentrically contracting, other group will be doing eccentric movement. That's the way this compression effect of the humeral head in the center of glenoid is constantly being done. And this is the very important function of the rotator cuff. And one has to remember about something called kinetic chain. So what is kinetic chain means? When you are doing a throwing movement, it's not just your hand is delivering the power of the throwing. The whole power of the throwing comes from the leg, trunk and back, and then it delivers to shoulder, and then elbow and wrist. And the wrist and hand is actually only giving about 10 to 15% of the whole power that is needed for throwing movement. And about almost 40 to 50% comes from leg, trunk and back, about 20 to 30% comes from shoulder, and the 10% comes from elbow, and the remaining 10 to 15% comes from wrist joint. So if you remember, if the player has to throw a ball, it is not just his wrist has to be powerful. He has to have a good power in the leg, has to have a good power in the torso. All scapular muscles should be very strong, and rotator cuff muscles should be strong. If some of them are not strong, for example, like the scapular muscles are not strong enough, then automatically he will put more pressure on the rotator cuff and is going to damage the rotator cuff. That's the way the players develop the cuff tear and cuff pathology. So, very important thing in any sports player is to have good physique, not only in terms of shoulder, in terms of the whole body. So they should also have the good aerobic capacity. So that's the first thing one has to remember whenever they get rotator cuff tear, and check whether they are using the correct biomechanics when they are doing the throwing activity. So next is when we call this an intrinsic theory. Intrinsic theory, what it means is rotator cuff at the attachment site, which is over the greater tuberosity area, is about 1 centimeter proximal to that area. The vascularity becomes much poor. Especially commonly happens around the age of 40 when they start degeneration. The vascularity of that area becomes less, and that is one of the reasons that has been sought about when the patient comes with rotator cuff pathology or shoulder pain. Other important thing to note is the anatomical morphology of the acromion. So Bigliani has found out 3 types of acromion. One is a flat variety, another is a curved variety, another is a hooked variety. So if you see the distance between the acromion and the greater tuberosity, or acromion and the coracoid process here, you see that the space is much higher in a flat acromion. Same thing is much lower in curved acromion and most lower in the hooked acromion. So there has been studies which have shown the patient who are having hooked acromion has got higher incidence of rotator cuff tear. Almost 73% of rotator cuff tear patients may have a hooked acromion, and only 3% of the patients with flat acromion will have rotator cuff tear also. But there is a good correlation between anatomic morphological change of acromion and also the incidence of rotator cuff tear. So if you just summarize the etiology, one is the overhead athlete, another is the intrinsic tendon pathology, another is the morphology of the acromion is different. At the end, the last one is due to trauma. Any trauma, if the trauma force is very high, it can tear the rotator cuff. So that is a fourth possibility. So in simple terms, etiology of the rotator cuff tear is multifactorial, and they can be classified into all these 4 things, which I told you earlier. So clinical features, we go into how they present. As already been told, shoulder pain is the commonest reason for shoulder pain is rotator cuff pathology. And I think most of the orthopedic surgeons, they write it as a PA shoulder. Very commonly, the missed pathology is rotator cuff pathology, and rotator cuff pathology can be a tendinosis, tear, partial tear, or a full thickness tear. And they will always tell aggravated by overhead activities. And night pain is a very important symptom, which shows the severity of the disease. And somebody who has got rotator cuff pathology along with adhesive capsulitis. Adhesive capsulitis means the shoulder is frozen, where the capsule has become thickened, and hence they will have global restriction of the range of movement, especially the external rotation. The first movement to get affected when somebody has got frozen shoulder is the external rotation. If anyone has got more than 20-degree difference in external rotation in compared to the other or normal side is, then they are going to the early phase of frozen shoulder. So night pain is one significant finding patients will have when they have rotator cuff pathology. And weakness, if they have rotator cuff tear, then they have weakness also. And sometimes the patients come with episodic pain, sometimes they are constant pain. All indicate the severity of the disease and activity-related pain. Some patients come with a history of trauma. Some patients will come with the only trivial history of trauma, which doesn't even correlate with what the symptoms are showing. So which indicates that they already had pathology and the trauma was only a supersedent and which was a trivial trauma which precipitated the event. So and the symptoms are most of the time is seen in the lateral deltoid area. Somebody asked a question earlier that how do you recognize the shoulder pain and neck pain? Most of the time shoulder pain comes over this area, the lateral deltoid. This is referred pain because the nerve supply for the glenohumeral joint and the lateral deltoid is same. Hence the pathology in the shoulder, they will reflect the pain over the lateral deltoid area. As same like when somebody has got hip pathology, they feel the pain in the anterior thigh or the knee joint. The same like that, they have the referred pain in the lateral deltoid. It's a commonest feature of the shoulder pain. And the test that you need to do in order to identify a patient with rotator cuff pathology or a subacromial bursitis is near test and Hawkins-Kennedy test. Near test is done by flexing the shoulder joint above 90 degree with pronation, and which means you are actually trying to impinge on the subacromial space, the space between the acromion and the greater tuberosity. You are trying to reduce that space. If there is inflammation there, then you will find out that that inflamed tissue will get friction on the upper bone or the lower bone, and they will cause pain. So that's what happens in near test. In Hawkins-Kennedy test is same, like you keep the elbow 90 degree and shoulder 90 degree and do internal rotation. The internal rotation is causing pain. It's called Hawkins-Kennedy test is positive. And Job's test is the next one to identify the supraspinatus pathology, especially for the supraspinatus weakness. So here what you are trying to do is keeping the shoulder in the plane of the scapula, which is like about 30 degree in the forward flexion, and keep in abduction about 60 degree, and put it like empty can. That is by pronation you're doing empty can, and do a resisted abduction movement. And if they feel only pain, it means supraspinatus tendinitis is there. If they cannot do it, for example, it's totally weak, it's probably either a supraspinatus tear or it may be due to pain inhibition also. How to differentiate that, whether it is pain inhibition or it is due to weakness? One, you can do a lidocaine injection and see whether the pain disappears. If the pain is disappearing, then we know the pathology in the subacromial bursa, and hence almost it confirms the diagnosis. It can be called as Neer test also, because Charles Neer is the one who identified all these findings, and hence the name is, and the test name is given to credits for him. Yeah, and the strength testing after lidocaine, for example, it is due to just tendinitis. The once after injection, they will be able to lift the shoulder up. But if there is a tear, which means weakness, even after injection, they cannot lift the shoulder. But that is one quick way of diagnosing whether the patient has got a pain due to tear or a tendinitis. So how does this impingement evolve? So now I already told you about what's the anatomy, what is the function, what is the etiology of it, how do they present it. But how exactly they evolve and that has been told by Charles Neer. Charles Neer is the most pioneer in the, we can be called as a father of the shoulder surgery, Charles Neer. As you can know, the Neer classification for proximal humerus fracture, and there is Neer prosthesis for hemiarthroplasty of the shoulder. And he is the one who identified what are the stages of impingement syndrome. And stage 1 is just edema and hemorrhage, typical age of patient around less than 25-year-old. And the clinical course most of the time is reversible, and the treatment is mostly conservative. And once they cross the stage of edema and hemorrhage, fibrosis and tendinitis occurs, where they start developing the range of movement restriction, which is almost called as frozen shoulder, and recurrent pain with activity, so activity-related pain. And in this kind of stage, you can try conservative management first. If that fails, then you can think about doing surgical intervention. Anyone more than 40-year-old with bone spur and tendon rupture can be called as a stage 3. This is the classical description of Charles Neer's stage 1, stage 2, and stage 3. So in terms of investigation, all the investigations are useful. X-ray can be useful to identify the acromiohumeral distance, sclerosis around the greater tuberosity, acromionization or acetabularization of acromion, or development of osteoarthritis like proximal migration, and you can even see the acromial spur also. The acromial spur means extra growth coming from the anterior aspect of the acromion, which, like hooked acromion, it impinges on the rotator cuff and causes tear also. The X-rays can be very useful in identifying all these things. And ultrasound scan can be useful to evaluate tendons, and MRI is useful to assess the rotator cuff tear, to identify where the tear is, how broad and how width is the tear, and also a very important thing is to assess the quality of the muscle. I think Dr. Seema already told about how to assess the quality of the muscle and all. It is to, that's for all these things, MRI is very useful. So in order to make an intervention, like surgical intervention, one must have MRI scan to have a clear picture of what we are dealing with it, and also to do a exactly planned intervention. So now let me go through partial tear to full thickness tear. So most important thing, just look at this gentleman who has got positive Hawkins test. So first thing he does is he elevates the scapula. It's a very common finding. I'll show it again. When you do is he elevates the scapula. And the left side, he will not do that. I'll do the same thing in the left side. He doesn't elevate the scapula. On the right side, he elevates the scapula. This is a very common finding in patients coming with impingement syndrome. And he is around 50 plus year old gentleman, and his main problem is shoulder pain. And if you see the MRI scan, he has got only tendinosis, he hasn't got a tear at all. And his main problem is actually the scapula is malfunctioning. And another gentleman, I'll just give this example. This person has got a pain over the scapula or the shoulder pain, and if I elevate the scapula and push the scapula to its normal position, his pain disappears. Again, he has also got scapular pathology. So he developed shoulder pain due to scapular dyskinesia. That's why he's getting this pain. So this is important to identify whether all these patients with partial cuff tear or full thickness cuff tear, do they have a scapular dyskinesia? And this is a classical one. This patient has got near full thickness partial cuff tear. So as you can see, the tear is in the bursal side, and it's almost near extending to the footprint area, coming down to the almost near to the bone. So almost like a near full thickness tear. And he, as you can see here, I'll just show it again. This one. He has got a severe Hawkins positive, flexion, internal rotation of the shoulder joint, causes severe pain. This is classical Hawkins positive, and I am trying to do the Job's test for him. And Job's test, he is able to do it, but he has got pain while doing it. Cuff tear incidence varies from 13 to 32%. As we become older and older, the incidence becomes much higher also. 5th decade, 6th decade, 7th decade, we have much more higher incidence of partial thickness rotator cuff tear. And it can be a bursal side tear or articular side tear. So depending on how thickness the tear is, it can be either a 1/4 thickness, 2/3 thickness, or just 1/3 involvement, 2/3 involvement, or more than that involvement. So 3 phases in articular surface tear and bursal surface tear. And the one articular surface tear can be colloquially also called as pasta lesion, otherwise called as partial articular surface tendon avulsion. So articular side is ruptured, so partial articular surface tendon avulsion, otherwise called as pasta lesion, PASTA, pasta lesion. So what is the treatment for all these patients coming with partial thickness rotator cuff tear is first to think about conservative management. They don't need operative intervention straight away. First of all, you need to identify whether there is any scapular dyskinesia and try to treat all these things. So try to give NSAIDs, do some physio activities in the form of doing modalities to soothe the inflammation over there, and then start on the rehab exercises. We can give a steroid injection in order to facilitate the physiotherapy, and not to really given as a routine course, just to facilitate physiotherapy so that they can change their scapular biomechanics, which will help to relieve the pain. So that is the reason for giving steroid injection. And see this one, scapula function. There are 6 functions of scapula. One is elevation, another is depression, one is retraction and protraction, another is downward rotation and upward rotation. These 6 functions of the scapula are very important. When there is incoherence in these 6 functions, then they will develop tilting of the scapula, so anterior tilting of the scapula. And that's what this gentleman has got. Okay, I'll just show you again. This gentleman has got anterior tilting. The scapula is looking like this. So when you have a scapula like this, you are seeing a patient with a rotator cuff pain or shoulder pain. Because out of 10 patients, almost 7 to 8 patients who are having partial thickness cuff tear will improve just by doing the rehabilitation properly. So listen to this. Is the scapula, normal scapula. Here is the anterior tilted scapula. When you have anterior tilted scapula, you will see the subacromial space becomes much narrower. Then they start developing impingement pain. If you correct this anterior tilting of scapula by doing rehab exercises properly, this space will become widened. Hence, that impingement pain will also go away. But that is something one has to remember, that rehab is the first mainstay in treatment of rotator cuff pathology, especially those who are having a tendinosis, intrasubstance tear, or a partial thickness rotator cuff tear. So somebody with extreme condition of scapular dyskinesia, they can go into something called 6 scapula, where 6 scapula means the scapula itself is totally abnormally functioning. Hence, they will see that inferior medial scapula border will be very prominent. So they can even develop a labral lesion or rotator cuff pathology. Both can be together. So remember that somebody, please take some time to identify whether the patient has got scapular dyskinesia or scapular mechanics which are totally wrong, and try to correct these. The patient will improve eventually with the good rehabilitation. So the same thing they can develop partial lesion. If they have a scapular biomechanics is very bad, then they can do impingement of the posterior superior aspect of the rotator cuff and also the biceps area. Hence, they can develop something called slap lesion or a partial lesion with slap lesion both together. Slap lesion is superior labral anterior posterior lesion. So the sixth scapula is scapula malposition. Inferior medial border of the scapula becoming prominent, and they sometimes start developing coracoid pain here and the dyskinesis of scapular movement. If you ask them to do abduction, their scapula will move incoherently. So that's what the scapular dyskinesia means, and the worst stage of that is sixth scapula. And all these patients, what they need is good rehab, and you have to focus on all these six muscles. I have written it clearly. Anterior deltoid has to be strengthened. Latissimus dorsi and levator. Lower and middle trapezius has to be strengthened. Rhomboid, teres major, serratus anterior. These are all the core scapular muscles which helps to keep the scapula very stable. And if these muscles are not working properly, and they will develop anterior tilting of the scapula, and they will develop anterior shoulder pain. So remember, rotator cuff pathology can be treated very well by doing a good rehab. So now this patient who has got scapular dyskinesia, we have subjected him for about 6 weeks of physiotherapy. Now you see after 6 weeks, he has got no scapular dyskinesia. He's not doing the upward tilting of the scapula. So remember, rehab is the first treatment, and that treatment works in almost 7 out of 10 patients, and they do get better in about 6 to 8 weeks time. If somebody is prolonging its symptoms more than that, then you should think about doing surgical intervention. This patient who has got fell off a ladder, has got pain in the shoulder since 8 weeks, he cannot abduct the shoulder joint. Passively he can do it, actively he cannot do it, and he's got a near full thickness tear. Rotator cuff is fully torn. Somebody coming with a traumatic full thickness tear, they are the one who are ideal indication for surgical intervention. If you do surgery on them, repair them properly, and they are going to get full range of movement and full function, and we can say that early repair is advocated in all those patients who are having a traumatic rotator cuff tear. But this patient had a traumatic rotator cuff tear, and we have done a repair. You can see it's seen from the articular side and also from the bursal side. If you nicely approximate it, and the healing is very good, and they will get better very, very well. And this patient is a 42-year-old factory worker, has got pain in the shoulder, but each time when you ask her to lift the shoulder, she will use the other hand to lift it like this, which means they are developing from partial tear to almost they are going to full thickness tear. So this is not a pure trauma. The 9-month history, she only lifted some heavy weight, and then she has been trying physio, and pain is not much improving. In 9 months, she's having pain, and Job test is positive, and MRI is showing a near full thickness tear along with the G tissue. And they are the patients, if you do physio, if they are not improving, then they should go and intervene for surgically. So this patient had a surgical intervention and had a repair of the rotator cuff tear by arthroscopically. So remember that first treatment for these patients who are having rotator cuff tear is conservative, and if conservative fail, then go for surgical management. And somebody who has got a large size tear, still the muscle quality is not too bad, and trivial trauma 2 months ago, before the muscle quality becomes bad or it becomes much retracted, try to repair it sooner. This is another indication where you repair before, when the muscle quality is good and the tendon is not retracted heavily, then they can be repairable very nicely, and the function can be got back sooner. To repair these people very sooner. And like, look at this one. Here the patient is 72-year-old, had trivial trauma, were not able to lift shoulder actively, and also passively we can do it. And he tried physio, and early evidence of OA is seen in the X-ray, and there is proximal migration of the humeral head, the acromial distance is reduced, and there is fatty atrophy also. These are the kind they are not good for surgery, and I mean they are not good for rotator cuff repair. They should be thought about other surgeries like reverse shoulder replacement, but these are not the ideal candidate for repair. First, try conservative management in this kind of patient. So I'll just summarize which one needs repair. So low risk patient, for example, large tear with advanced muscle change, like as I told you the last slide, with try to do conservative surgery only if persistently symptomatic. Try to do conservative management in this patient. Medium risk patient or acute and chronic tears, but function is well preserved, anterior disrupted, then do counseling of patient and rehab. If the rehab not improving, then go for surgical repair. Traumatic tears, acute and chronic tear, profound muscle weakness, good quality muscle, try to do early surgical repair. So this is the way you can take as an algorithm for how which patient needs surgical intervention, which patient needs rehab. So to conclude, patient counseling is very important in all these. So because once you have a rotator cuff problem, they are not going to recover in 2 or 3 weeks time. You tell an outcome figure of almost 3 to 6 months time. Whether you intervene or not, they are going to take that long. So tell a realistic outcome to the patients. So I tell that when I intervene in surgery to any patient, I tell 6 weeks they'll get 50% outcome. About 3 months time they'll get about 70 to 75%, and in about 5 to 6 months they're going to get about 95 to 100% outcome. So if you tell that realistically, their expectation is also realistic, and you can have good patient rapport along with them. So while doing conservative option, do well supervised rehab. If they don't do rehab properly, then they are not going to improve also. So remember, the rehab is very important. Do make sure that they are having it correctly. And when going for surgery, always tell realistic outcome. Thank you very much.
Thank you very much, Dr. Subra. Thank you. Excellent talk as always. 2 questions have come up for you. Number 1 is there a role for manipulation under general anesthesia for the shoulder?
Okay. I mean, it's a good question because it's a very debatable topic. Okay. Yeah. And manipulation under anesthesia is done for a condition like frozen shoulder, where there is loss of passive movement also, where somebody you cannot even lift the shoulder even by passive movement. Then you think about doing some activity to improve the range of movement. Okay. So the ways you can manage somebody who is having frozen shoulder is, first is you do rehab, physiotherapy. Most of them will improve physiotherapy. In a condition where they are not improving physiotherapy, then we are thinking about surgical intervention. Manipulation and arthroscopic capsularly. These are the 2 common modes of managing this. And manipulation is where you are doing haphazard release of all the structures that are fibrous. In arthroscopic release, you are doing a controlled release of whatever the structure is, which is very tight, which is anterior capsule. So, and there are multiple studies which have shown that there is marginal benefit or even good benefit if you do arthroscopic release and compared to the just MUA. So in my personal opinion, I hardly do manipulation under anesthesia for most of my patients. I go for arthroscopic release. But it is also an accepted practice. It is still debatable. The jury is still out. We don't know the exact answer for the question, but it can be equally acceptable answer in the exam if you say MUA. But when you are saying MUA, tell that you have to do very cautiously because there is incidence of fracture, and the maneuver is called fear maneuver, where F means flexion first, E means do extension next, A means do adduction and abduction, and then R means rotation last. So do control with a short lever arm, then the chance of fracture is very less. That's what I would say for the exam purpose wise.
Okay. Thank you, Subra. There was one more question. Is frozen shoulder self-limiting condition?
Yeah.
And if so, how long does it take to sort out?
Yeah. I mean, yes, frozen shoulder is a self-limiting condition. Yeah. It has got 3 phases where you got a freezing phase, frozen phase, and thawing phase. Altogether, leave it as such. If you don't intervene at all, and the patient should eventually get better from about 18 months to almost 3 years time. It's a long period for someone to keep on having shoulder pain. Okay, 18 months is somebody's life is very jeopardized for 18 months is intolerable. So it is a self-limiting condition. Intervention in the form of physiotherapy or whatever intervention is intended to reduce this self-limiting time. For example, somebody has got 18 months time, we can reduce it to lesser duration. That's the intention about management. I think is the explanation appropriate?
Yeah. Thank you very much, Dr. Subramanian. We'll go on to the next talk on shoulder instability by Dr. Sushal Shanthakumar.
Yeah. Hi. I'll try to share my design. 1 second. Is it visible? Yeah, am I audible? Is my PPT visible to everybody?
Yes, it's visible and you're audible. Thank you,
Okay.
Sushal.
At the outset, good evening to everybody who have viewed on the YouTube OrthoTV channel. Thanks to the Bone School team led by Dr. Thomas Kishen, my good colleague, and excellent talk by Dr. Subra, Dr. Seema, and Dr. Bhupesh. So this talk is predominantly aimed at the postgraduates. So the focus here is to tell you what the concept of instability is, what should you do, and how to identify it. I think Dr. Bhupesh has already told you about the test. So I'll just tell you about the pathology, the anatomy, and brief. I'll try to keep it in brief about what is the latest treatment we are giving, because it's always something up for debate, up for confusion. So I'll just briefly touch upon the bipolar bone loss and how to go about it. So yeah, let's start. So definition. So what is instability? So instability is basically inability to maintain the head in the glenoid fossa. So, and then comes the laxity. See, laxity is wherein there might be incomplete or partial loss of the articulation. However, the big difference is laxity is unassociated with pain. So you are either born with a lax shoulder, or due to some overhead exercises, or if you're an athlete, your shoulder may become lax over a period of time. So the key thing is laxity, it is not associated with pain. So dislocation, I think everybody is familiar where this complete loss of the glenohumeral articulation, and subluxation is partial loss of the glenohumeral articulation with symptoms. I think again, the patient has to be symptomatic to call it is a case of subluxation. So let's start with the compromise. The human body, I think everybody agrees, is a big compromise. Nothing is perfect. And the shoulder joint is a perfect example of that. So what is the compromise here? So it is a balance between stability versus mobility. So if you look at the joints in the body, no one joint is perfectly stable or 100% stable and 100% mobile. So stability is inversely proportional to mobility. The more stable a joint is, the less mobile it is, and the more mobile a joint is, the less stable it is. So a simple example I can think of for a stable joint is a hip joint. So if you compare that to a shoulder joint, shoulder is far more mobile but less stable when compared to a hip joint, which is much stable but less mobile. So similarly, the knee joint probably falls somewhere in between, where there is good mobility and good stability. So the point I'm trying to tell you is, when a joint is extremely mobile, so it is inherently unstable. So let's look at what is contributing to the stability with respect to the shoulder joint. So we have static factors as well as dynamic factors. So the static factors are the congruence of the articular joint, the version, the glenoid labrum, the capsule, and the ligaments. On the dynamic factors, which are predominantly the rotator cuff and a little bit contribution from the biceps tendon, then the scapulothoracic muscles, the negative pressure, and proprioception. So let's start with each one. With the osteology. So if you look at the glenoid fossa, it is pear-shaped with about 7 degrees of retroversion and about 5 degrees of superior tilt. The glenoid version, which is different from the glenoid fossa, is about 30 degrees anterior. Then you have the humerus neck shaft angle, which is 130 to 140 degrees. And then the retroversion. So if you look at the last slide here, so it's about 25 to 35 degrees of retroversion of the humerus with respect to the scapula. So coming to the joint, the glenohumeral joint, the head is nearly 3 to 4 times larger than the glenoid fossa. It's a ball and socket type of joint with translatory movement. You have 3 degrees of freedom: flexion and extension, abduction and adduction, internal and external rotation, along with circumduction. So in fact, some of the authors or some of the shoulder surgeons, we like to describe the shoulder joint as a golf ball on a tee. So if you look at this, this is the golf ball made up by the humeral head, and the tee is supported by the glenoid, and the blue beading is the glenoid labrum. So let's talk about the labrum in particular. So it's a fibrocartilaginous tissue. It is a static stabilizer. The predominant function is it deepens the glenoid by about 50 to 60%. So if you look at the picture here, you see it's like a beading. If you look at your car, the way the car door closes, there will be a black beading, which makes it airtight. So similarly, the labrum acts as some sort of a beading, or you can call it a stabilizer. So what are the 3 purposes? It increases the contact area, the surface contact area between the glenoid and the humerus. It acts as a buttress, and also it provides an attachment site for the glenohumeral ligaments. So coming to the capsule and ligaments, let's start with the capsule. It attaches medially to the glenoid fossa. So if you look at it, this is your medial attachment to the glenoid fossa. Laterally, it's to the anatomical neck of the humerus. Something you should observe or something you should know is anterior capsule is far more thicker than the posterior capsule. In fact, posteriorly, the superior part of the posterior capsule is completely non-existent. Capsule provides for about only 2 to 3 mm of distraction, which is the normal amount. There's little contribution to the joint stability. This is stabilized by the glenohumeral ligaments and the rotator cuff tendons. So let's start with the glenohumeral ligaments. So we have 3 ligaments: the superior glenohumeral ligament, the middle glenohumeral ligament, and the inferior. So the first one is the superior glenohumeral ligament. So the origin is from the glenoid tubercle, just posterior to the long head of biceps. So if you see, this is the origin, and is inserted into the lesser tubercle. So it resists inferior subluxation and contributes to the stability in posterior and inferior directions. So this is the superior glenohumeral ligament. So it arises from here, just in front of the long head of the biceps, and inserts here. Next comes the middle glenohumeral ligament, arising from the superior glenoid and the labrum. Inferiorly, it blends with the inserts into the subscapularis tendon. It limits the anterior instability, especially in 45 degrees of abduction. And it also has a role in limiting external rotation. In fact, you need to keep in mind the Buford complex. Buford complex is a normal variant wherein it's a thickened middle glenohumeral ligament. Sometimes when you ask for an MRI, you might see a thick middle glenohumeral ligament with absent labrum. This is not a labral tear, but a normal anatomical variant. In fact, if you were to end up tightening the MGHL, then there will be a loss of external rotation. Coming to the main ligament, the most important, the IGHL, the inferior glenohumeral ligament. Origin is from the anterior glenoid rim and the labrum, and inserted into the inferior aspect of the humeral articular surface and the anatomical neck. So if you look at it, it acts. So this is the inferior glenohumeral ligament. It has got 3 bands: the anterior band, the axillary, and the posterior. Out of which the important is the anterior. So this is how it is. This is a good diagram. So this is the anterior part, and you're looking at the axillary, and from posteriorly you can make out the posterior other side. So it supports the shoulder like a hammock, and its main support is about 45 to 90 degrees of abduction, which is the main position where the shoulder dislocates anteriorly, abduction, external rotation. So IGHL is one of the predominant static stabilizer. So now let's talk about the dynamic stabilizers. So among this, the main one is the rotator cuff. I think Dr. Subra told you pretty much everything you need to know. So he says the main function of the cuff is not movement. It is to stabilize the humeral head against the glenoid fossa. In fact, it provides compression, and this compression enhances the conformity. So it's coordinated contraction and the steering effect, which keeps the head in position. Out of all the muscles, the supraspinatus is the most important. It is the main function is to depress the head or to keep the head into the glenoid fossa, and not abduction as clearly taught, I think, in most MBBS books. Supraspinatus is not an initiator of abduction. In fact, the main function is to depress or keep the head in position. The next one is the LHB, the long head of biceps. These are all secondary stabilizers. It's got a role in depressing the head. The scapular muscles, they position the scapula and orient the glenohumeral joint. It contributes to compressive forces across the joint. So one word about the scapulothoracic motion. So compared to the glenohumeral, which is the main movement, scapulothoracic also contributes. The ratio between the glenohumeral and scapulothoracic is about 2:1. I think Dr. Subramanian showed you when there is a rotator cuff pathology, the patient inherently lifts the scapula, the scapular dyskinesia. This is what happens. When there is glenohumeral movement restriction, the scapula tries to overtake the movement. And the 2:1 ratio is, it's probably inverse, or there is equal the same movement. The scapulothoracic muscles, which are the trapezius and the serratus, teres major, and levator scapulae, like I mentioned, they help in the compressive forces against the joint. It's a less stable platform compared to the rotator cuff muscles. The other dynamic stabilizer is the negative intra-articular pressure. On cadavers, it has been shown to about minus 40 centimeters of water. It's clinically important only in the arm in rest in adduction, and the effect is lost in this thing. How do I put it? In lax capsule or defects. Next, the proprioception. It is significantly reduced in unstable shoulders, but returns to near normal in reconstructed shoulders. So this is a simple chart which you guys can look at. So on one hand, you have the static, on the other hand, the dynamic stabilizers. The predominant static stabilizers being the labrum, consisting of all the 3 glenohumeral ligaments. And the other side, you have the joint capsule. Among the dynamic stabilizers, the predominant one is the rotator cuff muscles, which is again the predominant rotator cuff is the supraspinatus, and the scapular muscles less important, but they do contribute to the dynamic stabilizers. So what do the static stabilizers do? They deepen the fossa and maintain the negative pressure. What do the dynamic stabilizers do? As I mentioned and Dr. Subramanian mentioned, they maintain the head in the glenoid fossa throughout the range of motion. The scapular muscles is they maintain the scapular stability. So that was the anatomy. Now let's come to the pathoanatomy. There are a number of lesions which occur when the shoulder dislocates, be it for the first time or every recurrent dislocation. Starting with the labral side. So you can have a Bankart lesion, a reverse Bankart, or a slap lesion. Coming to the capsule, you can get an intrasubstance tear of the capsule. Then you have the Hegel lesion. What is Hegel? Hegel is humeral avulsion of the glenohumeral ligament. Bankart is glenoid avulsion of the glenohumeral ligament. Hegel lesion is the humeral side of the glenohumeral ligament is torn. And then you have capsular laxity. Next, the bone loss. If there is bone loss on the glenoid side, it can be a acute fracture, which we refer to as a bony Bankart, or it can be a subsequent gradual erosion, wherein there is glenoid bone loss. On the humeral head, the defect is known as Hill-Sachs lesion, where the posterolateral, typically in anterior dislocations, the posterolateral humeral head demonstrates a defect. If it's a posterior dislocation, you might get even a reverse Hill-Sachs lesion. So let's start with one by one. So as I mentioned, Bankart is the traumatic detachment of the anterior-inferior labrum, as you can see here. So when only the labrum detaches, it's called a soft Bankart or the soft tissue Bankart. Sometimes when it takes a chunk of the bone, it is known as a bony Bankart. So a Bankart lesion is seen nearly in 85 to 90% of the shoulder dislocation, and it was initially described as proposed as an essential lesion first by Bankart. Then you have the Hill-Sachs. As I mentioned, this is a defect in the posterolateral head of the humeral head. In case of anterior dislocation, you can see here, this is the Hill-Sachs lesion. In case of posterior dislocations, you will see a defect on the anterolateral part. So this is a AP view of the X-ray. You can see this is the Hill-Sachs defect, and this is a striker nodule, typically showing a posterolateral defect in the humeral head. This is the Hill-Sachs. So now let's coming to classification. I think this is important for you on exams and also the same. There's a number of ways you can classify. Based on the frequency, it can be acute dislocation, recurrent dislocation, or it can be a fixed dislocation, typically chronic, where dislocation might have been missed. And most commonly, the posterior dislocations are the ones which are missed compared to the anterior. Etiology wise, it can be a traumatic dislocation or you can say a macro trauma. Atraumatic, it can be voluntary or involuntary. Then you have micro trauma, where classically the patient presents you with subluxations. Then you have a congenital condition. Any neuromuscular conditions such as epilepsy, seizures can cause dislocation. You can categorize it depending on the etiology. In direction, anterior dislocation, which accounts to about 90 to 95%, posterior dislocations. Inferior, typically you don't see isolated inferior dislocations. It is in common with anterior, posterior, inferior dislocations. And finally, the multidirectional. This could be atraumatic or lax shoulder. Depending on the degree, you can classify it as a subluxation or dislocation, like I mentioned. One word about Matson's classification. I think this will help you overall, in a nutshell. So he classified it into Tubbs and Ambry. So what is Tubbs? Traumatic, unidirectional, with a Bankart lesion and treated by surgery. So surgery is often necessary in cases of trauma unidirectional Bankart lesion. Coming to Ambry is atraumatic, multi-directional, most often and not bilateral, because patient is born with laxity. We use something known as Baton score. I think Dr. Bhupesh already told about it. Then rehabilitation is a treatment of choice. With, if at all you're looking at surgery, you'll have to do an inferior capsular shift. So these are most often treated with rehabs. So in other ways, tubs, they're torn loose, Ambry, they're born loose. So this is another good slide for you to understand what we are talking about. All traumatic cases have less laxity and they're unidirectional, which are treated by surgery. So on the other end of the spectrum, you have the atraumatic or the congenital ones, which are more lax and they're multi-directional. In between, you have the microtrauma, wherein they might present to you with subluxation, with probably not typical dislocations. Coming to epidemiology, the incidence is about 2% over your lifetime. As I mentioned, the anterior is more common, the most commonest, and typically occurs in athletes in younger groups. Males are more commonly affected than females. So another important thing is the prognostic variables. What are the variables which discuss or which decide whether a shoulder dislocation is going to recur? First, the gender. So there is no correlation if you look at the less than 30 years of age group. Next, coming to the hand dominance, again, there is no correlation, it has been reported. Initial trauma, it's a controversial topic, whether the amount of the trauma which the person sustains correlates with the recurrence or not. Sports participation, people who are active, people who are overhead athletes are more likely, that they will have a further recurrence. Initial X-ray appearance, I think you people all know, anything which is associated with the fracture has got a lower rate. So again, hence the trauma is controversial. Looking at that, you can argue saying more the trauma, less the recurrence. However, it has not been substantially proven yet. Period of immobilization. This is also another topic. Following the first episode of dislocation, whether immobilizing the patient in a sling or immobilizing in a shoulder immobilizer for longer period of time, will it lessen the recurrence? Again, it is unclear. And if you ask me, I don't think period of immobilization has got any role whether the patient has got any recurrence or not. So what is the most important factor? Yes, age. The biggest prognostic variable is the age. So lesser the age of the patient, younger the patient, higher the recurrence. How much? Let's see. So the multiple studies, if you look at all the studies, I'll just brush through this fast. McLaughlin and Cavallaro said 90% of the patients lesser than 20 years have a recurrence. Rowe said the percentage goes up to 94%. Henry and Genung said it's about 88 to 90%, regardless of the type of treatment, of the non-operative treatment. Cofield said it's about 60 to 66%. And Arciero said it's about 80%. So basically what you can take home is younger the age patient, higher the recurrence. So I will skip this part, evaluation. As always in orthopedics, everything starts with the history. As I mentioned, age is the voluntary subluxation. If it is a voluntary case, I think you should leave him alone. Do not operate on any voluntary subluxations because there's a higher chance of recurrence of your surgery failing. Look for any clunk or knocks, especially the patient says every time I abduct and externally rotate, I get a knock. And apprehension, I think this has been talked about. I think the positive apprehension and relocation test, number of dislocations and the energy associated, history of first dislocation or injury, and subsequent subluxations. Again, I'm gonna just skim through this. I think this has all been spoken about. Sulcus sign, the drawer, the load and shift sign. Dr. Bhupesh has spoken about this extensively. So only one test, this thing is, for me, the most important test clinically is the apprehension test. So there is the anterior as well as a posterior apprehension. When you abduct and externally rotate, as you can see in the figure, you stand behind the patient, stabilize the scapula, and you abduct to 90 degrees and externally rotate. Typically, the patients are scared, along with pain. Some patients might say the pain, and some of the ones typically they're apprehensive. This is a positive apprehension test. And then you have the same thing what you do when the patient lying supine. You put the shoulder in an abduction, external rotation, press the shoulder anteriorly, and the patient says the patient feels better. And then when you release the pressure, there is a recurrence of symptoms. Patient says this pain. So this is a Job's relocation. So diagnosis, start with the X-rays. X-rays, you can identify the Bankart or Hill-Sachs lesion if you can have a keen eye. As you can see the Bankart lesion, but most often than not, X-rays are normal. So this is the posterior superior defect in the head, that is the Hill-Sachs lesion. So there are certain special X-rays. You start off with a true AP view. How do you take a true AP view? As I mentioned, the scapular plane is at about 30 to 40 degrees. So the true AP view is about 45 degrees lateral, and the patient can be sitting, standing, or lying down. So in the true AP view, the inferior glenoid becomes much more visible, and the Hill-Sachs. This is an axillary view where the cassette is kept superiorly and the beam is directed from the axillary side. And you can see very nicely, you can appreciate the glenoid bone loss and the bony landmarks. So as you can see, this is an anterior dislocation on my slide. Then you have the scapular Y view. This is again tells us this is useful in case of posterior dislocation. See whether the head is anterior or posteriorly dislocated. Striker notch view, again helpful for Hill-Sachs defect. Some of the other views are sometimes the patient is unable to completely abduct or completely in case of striker notch. So then you can do a West Point axillary view. This shows us the anterior-inferior glenoid rim. There are other views, the Bernadette, the Bernagauge view and all. I think you can read about it. So let's come to the most commonest, which is the anterior dislocation. So typically the shoulder is in an abducted, extended, and an external rotated view, external rotated position. The various types are the subcoracoid, subglenoid, and the subclavicular. Some of the associated injuries could be fractures, head and neck of the humerus, rotator cuff tears, especially in the older age group. If the patient is old, I think you'll have to rule out rotator cuff tears. The incidence is almost 80% in about people who are older than 60 years. Neurological injury, most commonly the axillary nerve is involved. That's about 10 to 25% incidence the first time. Only about 2 to 5% in the recurrent dislocators. Treatment is just watchful expectancy. If there is a poor prognosis if there is no recovery. Vascular injury, look for the axillary artery injury. It's normally the second part of the thoracoacromial trunk which is injured. So now let's come into the treatment. So see, one of the main causes of shoulder dislocation is a Bankart lesion, which is supposed to be the essential, and the bone loss. So there is hardly any role of non-operative treatment or rehabilitation in case of traumatic dislocators, whether be it first time, which is up for debate, I'll just come to that, or especially in the recurrent dislocators. So the non-operative treatment is usually reserved for the atraumatic, those who are born with congenital laxity. You do a Baton score and see if it's more than 7 or 8, you treat them conservatively. So there is not much role of for strengthening exercises. However, you can do a range of rotator cuff strengthening exercises, especially for the atraumatic cases. So what are the current concepts? Now let's start with the first time dislocators. So Buttoni reported about 75% of redislocation in the non-operative group versus about 10 to 11% in the operative group. Similar incidence was found by Kirkley and Richards. About 50% recurrence in the non-operative was about 15% in the operative group. So progressively, if you look at this, we shoulder surgeons are also offering surgery for first-time dislocators in which condition? Especially those who are high risk, high demand activities, and younger age group. As I mentioned, age is one of the biggest prognostic factor. In certain type of athletes, for example, mountain climbers or construction workers, even first-time dislocators are indicators for surgery. If there is a recurrence of dislocation or if there's subluxation, if the trauma was treated adequately with non-traumatic measures, and pain, there is a separate category called unstable painful shoulder. If there is pain due to recurrence, subluxation, especially in overhead activities and in athletes, so they also are candidates for surgery. So what are the operative treatment which is available right now? So just to complete historically, certain procedures which you have presently, the capsulolabral repair, the Bankart, Then you have the subscapularis procedures, the putty plat and the Magnuson Stark, which are surgeries just for academic interest, which are not routinely performed. And then you have the bony procedures, which is the Bristow Latarjet procedures and the Ilacris bone transfer procedures. So let's start with the Bankart. See, whether you do it open or arthroscopic is totally up to you, but Bankart is the procedure of indication provided there is no bone loss. So what do we do in Bankart? So the labrum is reattached to the glenoid so that you're giving an attachment for the inferior glenohumeral and the middle glenohumeral ligaments back to the glenoid. So this is attached to the glenoid using surgical anchors and sutures. So I do have a video, but I think I'll skip that. So I think you guys already know what we do. So if you look at this, you use suture anchors, whether you use suture anchors or bioabsorbable or metal anchors is your choice. But you're actually attaching the labrum back to the glenoid. See, again, this is also another picture. So then you have the Latarjet procedure. So what is Latarjet? Latarjet originally described by Bristow, then Latarjet modified it. So this is in cases of people who have anterior glenoid bone loss, anterior inferior glenoid bone loss. You cut the coracoid and you transfer it to the anterior inferior glenoid rim. So as you can see in the picture here. So I just like to mention one point about the bipolar bone loss, which is the new concept right now. So this was developed by Itoy, Burkhardt, and Giovanni together. So this is what they came up with. So Itoy did a 3D CT and decided that with the arm in 90 degrees of abduction, the glenoid tract or the amount of the humerus which is in contact with the glenoid is about 83%. So this is what we call glenoid tract. So this can be confusing, but I want you guys to read about it if you want more information. So I'm just going to brush about it. So basically what you need to know is 83% of the glenoid is known as a glenoid tract. Any bony defect which is less than that will contribute to bony instability. So after that, he measured the Hill sacks. So if the Hill sacks falls within the glenoid tract, then it is an on-track Hill sacks lesion. Suppose if the Hill sacks is broader than the glenoid tract, that means if the Hill sacks is bigger, so then it is known as an off-track lesion. See, if you can see in this picture, the bone loss is more than 83%. So in such cases, it's known as an off-track Hill sacks lesion. So this is the one take-home message what you can take from this. So if the bone loss is around 25%, less than 25%, and you have an on-track Hill sacks, a simple soft tissue arthroscopic Bankart repair will suffice. If the bone loss is less than 25% and the Hill sacks is engaging or off track, then you might have to supplement with a remplissage procedure. Now coming to the extremes of bone loss, where if the bone loss is more than 25% and the Hill sacks is on track, a simple Latarjet, as I described, whether you do an open or an arthro Latarjet is your choice. Latarjet procedure will be the indication. In cases where the bone loss is more than 25% and the Hill sacks is engaging, meaning it's off track, then you might also have to address the Hill sacks lesion as well. Whether you can do a remplissage bone grafting or you can even do a resurfacing. So I think this is, see, I'm just brushing the concepts. There's much more deeper I want you guys to understand if you want to go in detail. But I think this is the summary I can give you. Look for the bone loss and look whether the Hill sacks is engaging or non-engaging. So how do you know whether the Hill sacks is engaging or non-engaging? This is through arthroscopy. However, you can decide whether the Hill sacks is on track or off track through a CT scan and complemented with the opposite side as well. I think your radiologist will help you in that. So this is, I like to conclude this. So the balance between the restoration of the joint stability while minimizing the loss of glenohumeral motion, that should be the focus of the treatment. And the choice of the treatment should be individualized, looking at the bone loss and whether the Hill sacks is on track or off track. This is the newer concept which is known as bipolar bone loss. I think I'd like to conclude my time with that. And thank you for your attention.
Thank you very much, Sushal. Excellent lecture as always. We are slightly running out of time. So before we end, I'll ask you a quick question. Somebody asked, a patient older than 65 years with dislocation, recurrent dislocation, would they benefit from surgery or you treat them conservatively? Recurrent dislocation above 65.
Yeah, again, see, as I mentioned, any patient above the age of 60, 65, in fact, they will most definitely have a rotator cuff tear. So I think it is a given. So now the question comes, if there is not much of arthritis and there is a rotator cuff tear, if the glenoid labrum is significant, I'd probably do a labral repair and a rotator cuff repair. However, most often than not, in my 70 to 80%, I think a simple rotator cuff repair would suffice. If this patient has got multiple recurrent dislocations with sufficient glenoid bone loss and the head is completely arthritic, then I think there is no role of repair or anything. Then you're looking at replacement, whether you do a total shoulder or a reverse shoulder.
Okay. Thank you very much, Dr. Sushal. I think we'll end because we are on YouTube and we've finished our slot. Thank you very much. A big thank you to Dr. Subramanian, Dr. Bhupesh Karthik, Dr. Sushal, and Dr. Seema. Thank you very much for taking your time off to teach at Bone School this month. A big thanks to Dr. Neeraj and Dr. Ashok from OrthoTV for helping broadcast our program across the world. Thank you very much, gentlemen, and thank you all for attending. I hope you found this useful. Feel free to get in touch with us on social media, either on Instagram or Facebook. We have an Instagram is Bone School. Our Facebook group is Bone School @Bangalore. So please get in touch with us if you have any questions or if you want information about our courses. And with that, we come to the end. Thank you very much, gentlemen. Big thanks to the faculty who've always been a good support, big support. Thank you very much. Thank you very much, Neeraj and Ashok also. Thank you. We close the session. Thank you, gentlemen. Thank you. And thank you, Dr. Seema.
Yeah, thank you, everybody. Bye-bye.
Thank you.
Thank you very much.
Thank you. So we'll shut the group. Thank you. Thank you.